Now we are continuing our program with our prominent speaker, Dr. Waleed AlSowayan. He's a pulmonary medical and pulmonary rehabilitation consultant at Security Force Hospital and the head of pulmonary division at Security Force Hospital. Please welcome with me Dr. Waleed AlSowayan, who will be talking about the current management of IPF. Dr. Waleed, please.
Okay, thank you very much, Dr. Hajar, for the nice presentation. Thank you for the attendee. I'm very happy and glad to be with you. To be honest with you, my colleague made my life easy because they covered a great proportion of my talk. So in the coming 15 minutes, I will speak about the current management of idiopathic pulmonary fibrosis. As mentioned before, IPF is a progressive fibrotic lung disease characterized by worsening respiratory symptoms as well as physiological impairment. It is a specific form of ILD with radiological and histological pattern of UIP in the absence of environmental factors and other known causes of ILD. As mentioned by Prof. Jdeer, the estimated global incidence of IPF range from 1 to 13 per 100,000 person, and the prevalence range from 3 to 45 per 100,000. And the highest number globally reported from South Korea and North America. But remember, one of the vision of our country is to increase the lifespan of the community. So we are expecting the IPF to move from the rare disease soon. Risk factors are also discussed with my colleagues. Remember, always think about IPF when you face a patient who is older than 60 years of age. It is more prevalent in male. Dr. Raed, he went thoroughly through the genetic risk factors in all levels, starting from the host defense, telomer maintenance, surfactant processing, epithelial integrity, as well as fibrotic signaling. I will not go through these since my colleague Dr. Raed discussed it already. Remember, there is a strong association with cigarette smoking, air pollution, and occupational exposure. So you have to focus in the history when you look for a patient who has IPF. And also remember, there is a significant comorbidity, including gastroesophageal reflux as well as obstructive sleep apnea. And these diseases are very prevalent, but still the causative role hasn't been clearly established. Family history is very important also. The most important first step is to establish the diagnosis, since misdiagnosis can lead to inappropriate initial therapy. The diagnosis of IPF may be established with a high degree of confidence in patients with a compatible clinical presentation plus typical features of high-resolution CT scan. So if the high-resolution CT scan showed definite pattern, then you can diagnose your patient. If you are still in doubt, then you have to go further more with more diagnostic workup, which should include pulmonary function test, 6-minute walk test, bronchoalveolar lavage, and plus minus surgical lung biopsy, or the other alternative is transbronchial lung cryobiopsy. Just to revise with you, in the left photo, this is a typical UIP pattern. Clearly, there is subpleural lower lung predominant reticular abnormality with honeycombing and traction bronchiectasis. So this is typical UIP. In the middle photo, this is a probable UIP, and you can see that the pattern is peripherally located with numerous bronchiectasis, but in the absence of the typical honeycombing. In the right photo, this is the indeterminate for UIP pattern. Here you see that there is a heterogeneity with subpleural lung infiltration, but you see clearly that there is a significant amount of ground glass opacity. So this is definitely indeterminate for UIP, and you need to investigate your patient more and more. Treatment options, there is pharmacological medication available in the market, FDA approved, and there is also non-pharmacological management. The pharmacological management include the two important medication, nintedanib and pirfenidone. And in the non-pharmacological treatment, we should look for the indication of supplemental oxygen for our patient. And most of the indications of oxygen therapy in the field of pulmonary medicine came from COPD studies. Pulmonary rehabilitation is another very important aspect of treatment. Pulmonary rehabilitation per se showed to improve clinical outcomes in patients with IPF, including improved shortness of breath and the quality of life. It is very important to look for the nutritional status of our patient and adjust the weight. Vaccination is a very, very, very important aspect when it comes to the management of IPF. And eventually, when the patient at the level of lung transplantation, it is very important to think about it and refer him as early as possible if he has the indication to go for lung transplantation. The validation of the two important medication, starting with pirfenidone, came from many trials. The capacity trial, which was published in 2011 in The Lancet, showed clearly that the pirfenidone reduced the decline in forced vital capacity when we compare it with the placebo. And it also improved the progression-free survival, and also it reduced the rate of decline in the 6-minute walk test. And the studies showed clearly that the commonest side effects include GI symptoms, photosensitivity, and rash. In 2014, in the New England Journal of Medicine, the ASCEND trial came, and it showed almost the same result, that the pirfenidone reduced the disease progression, reduced the rate of decline in 6-minute walk test, reduced the risk of death at 1 year by almost 50%, and improve the progression-free survival. I want to remind you that the pirfenidone is antifibrotic agent that inhibit transforming growth factor beta, stimulated collagen synthesis, and block fibroblast proliferation. The dose of pirfenidone range up to 40 milligram per kg per day to a maximum of 2,403 milligram per day in 3 devices, divided doses. So always there is an issue with compliance when it comes to the pirfenidone, because the patient has to take it 3 times per day. The other validated medication is nintedanib, and nintedanib is a receptor blocker for multiple tyrosine kinases that mediate elaboration of fibrinogen growth factor. It was studied in many studies. Tomorrow study in 2011 showed clearly that nintedanib, when you compare it with the placebo, reduced the decline in the forced vital capacity, reduced the disease progression, improved the quality of life, and the side effect more or less the same of pirfenidone, GI symptoms, as well as elevated liver enzymes. In the Impulses trial, which was published in the New England Journal of Medicine 2014, again, nintedanib showed a reduction in the rate of decline in the forced vital capacity, and it showed clearly improvement in the quality of life, and the side effect was almost the same like pirfenidone, GI symptoms with elevated liver enzymes. So when we should start the treatment? Shall we wait and watch, or shall we start the treatment as soon as possible? And the literature showed us clearly that we should initiate the treatment as soon as possible. Why? Because IPF has a poor prognosis. The median survival at the time of diagnosis is 3 to 5 years, which is worse than many cancers. And again, in IPF, it is always unpredictable behavior. Some of the patients, they will progress very rapidly, and some of them, they will progress slowly. So you cannot predict which is which. So it is always advisable to start the antifibrotic as soon as possible. IPF clearly showed progression a progressive decline in the forced vital capacity. When you compare the IPF patient with the normal individual, the normal individual, the rate of decline is almost 20 to 30 ml annually. When you see for the IPF patient, it is almost 200 ml. And the change in the forced vital capacity is associated with increased mortality. If there is a change more than 10%, decline more than 10%, this is associated with 5-fold increase in the risk of mortality over the subsequent year. Not only that, but when we looked for the studies conducted by pirfenidone and nintedanib, for example, this study, which was published in 2016, looked for the efficacy of pirfenidone in patients with idiopathic pulmonary fibrosis with more preserved lung function. They categorized the groups to two groups: the patient with more preserved lung function, I mean forced vital capacity more than or equal to 80 with a gap stage 1, and the other group with less preserved lung function with a forced vital capacity less than 80 and a gap stage 2 to 3. And what they found that there was a clinical significant disease progression at 12 months in both groups, and the magnitude of pirfenidone treatment effect was comparable between subgroups. So it is advisable by this study to initiate pirfenidone as early as possible. What about nintedanib? Also, another study published in 2017 in the Thorax Journal looked for the nintedanib in patients with idiopathic pulmonary fibrosis with preserved lung volume. And again, they categorized the patient based on the forced vital capacity, more than 90 or less than 90. And the result was almost comparable. The treatment with nintedanib slowed the annual rate of decline in forced vital capacity in both groups to the same extent. So if you initiated nintedanib early, the result is always promising. So when we should we stop the treatment? There is two indications. Number one, if there is unbearable side effect, and number two, if there is lack of efficacy. And what do we mean by lack of efficacy? In the literature, they define the lack of efficacy as an absolute decline in the forced vital capacity more than or equal to 10% after 6 months of treatment. So this is indicate an inadequate response. So surgery, as you know, may expose the patient to a significant risk of acute exacerbation, which may occur in 20% of the cases. It is always come to our practice. Shall we stop the antifibrotic treatment for the patient who is going for surgery? And this study assessed the risk of efficacy and safety of perioperative pirfenidone for prevention of acute exacerbation of idiopathic pulmonary fibrosis in lung cancer patient undergoing pulmonary resection. So what they did in their study, they gave the pirfenidone until the morning of the surgery and then restarted as soon as possible when the oral diet given to the patient. And there was no serious adverse event observed, and the acute exacerbation of IPF didn't occur in 37 out of 39 of the patient, which is a good number, because when you look for the literature, usually the risk of acute exacerbation after surgery reach up to 20%. I will conclude with a very nice retrospective cohort study published by our colleague from the National Guard Hospital. They looked for their real-life data regarding the nintedanib and pirfenidone. And just I will share with you two important. It was published recently, 2023, in the Annals of Thoracic Medicine. And I found it very interesting because what they noticed in their cohort study that there is increase in the number of hospital admission in the group started with pirfenidone when they compared them with the patient who was started on nintedanib. And number two, regarding the side effect, both of the medication known to cause GI side effect, but what they noticed in their cohort that the patient with nintedanib usually they have lower GI symptoms, and the patient with pirfenidone they have more of upper GI symptoms in the form of nausea and vomiting. So to conclude, IPF is a disease with high mortality. Antifibrotic are not curative but effective. Early treatment initiation is important. Always monitor for the side effect and screen your patient for lung cancer. Thank you very much.